Hello, my name is Konstantinos Boudoulas. I'm the Director of Interventional Cardiology at the High State University in Columbus, Ohio, in the United States of America. I want to thank the President of the Society, the organizing chair and committee for this wonderful opportunity to provide this lecture to you all. Today I'm going to talk about cardiac arrest, chest compressions to extracorporeal membrane oxygenation, or ECMO. And during this lecture, I will share our experience here at the High State University. I have no disclosures relevant to this lecture. Winston Churchill in 1940 stated, "Never in the field of human conflict was so much owed by so many to so few." He was referring to the Royal Air Force during World War II. And the same could be said to the individuals who have contributed to the field of cardiopulmonary resuscitation, or CPR. There's really a few early on that have paved the way to where we are today with CPR and cardiac arrest. And I'd like to touch base a little bit on the history of what got us to where we are today. In 1874, Mortis Schiff, who was a German physiologist, described the first open chest cardiac massage in a laboratory animal. This was a nice quotation that came out of the practitioner back in 1874 that stated, "The heart is in vital state favorable to its renewed action when paralyzed by the influence of chloroform on the vasomotor nerves, is demonstrated by Professor Schiff's practice of artificial circulation. He lays open the thoracic cavity and, compressing the passive heart with his fingers, imitates it in the periodic movements of the organ. The circulation is restored, the nerves of the heart recover their force, and the organ finally resumes its spontaneous action. Before long, signs of returning sensibility become apparent, the reflex action of the eyelid return, and the animal is now capable of being brought back to the cerebral consciousness." What a wonderful description of the open chest cardiac massage by the German physiologist. Then a few years later, in 1892, the first successful closed chest cardiac massage was reported by Frederick Maas, who's a German surgeon, on a 9-year-old boy who was undergoing cleft palate repair. The quote that Dr. Maas stated in 1892, I now had to consider the patient dead. Nevertheless, I went to direct compression of the heart region, and in my excitement, I worked very fast and vigorously. The pupils quickly constricted, and when I continued at great speed, they were soon smaller, and during pauses, the slow, gasping respiration started up again. You know, after this event, nearly 70 years went by before closed chest compressions was revisited, and I'll get to that in a few slides, and takes us to where we are today. So really, these contributions were forgotten for nearly 70 years. In 1901, the first successful open chest cardiac massage in a human was performed by Dr. Christian Igelsrud, who was a Norwegian physician that performed this resuscitation in a cardiac arrest patient during an elective hysterectomy, and had successful open chest compressions. And then 70 years later, from the first closed chest cardiac massage by Frederick Maas in 1892, came William Cohenhoven, who is the pioneer of what we are doing today when it comes to CPR. This is a picture of Dr. Cohenhoven on the left. In the middle is a schematic of the CPR that he described, that was published in JAMA in 1960. And on the far right, you can see the blood pressure tracing of an adult with these closed chest cardiac massages. So really, 70 years after the description from Frederick Maas. And this is where we are today. However, we have evolved to even now be able to perform automated CPR resuscitation using certain devices. This device here is called the Lucas device. You can see it's a piston that provides effective and efficient chest compressions, about 100 per minute. It also allows for full chest recoil. This is a patient in our cath lab who was in cardiac arrest. The automated CPR device improves cerebral blood flow compared to manual CPR, particularly in the pre-hospital setting. And it's very important to mention that CPR from the field out of hospital to the hospital can be very difficult when an ambulance is traveling very fast for the personnel to give adequate compressions. And this device can provide the quality and the consistency of compressions for organ perfusion. Now, let's take it one step further. There's a nice publication in 2020 that actually shows that artificial intelligence using the Lucas device that I just showed you can provide better coronary perfusion and cerebral blood flow than a human. This artificial intelligence uses a computer system that monitors coronary perfusion and monitors cerebral blood flow and adjusts the compressions and decompression to optimize the flow. Again, better than humans. And now taking it to even a step further is eCPR, which I will describe in the next several slides. So eCPR is extracorporeal cardiopulmonary resuscitation, which essentially utilizes ECMO as an adjunct to CPR. Now, ECMO, as you know, is an extracorporeal outside-of-the-body technique that provides both cardiac and respiratory support, i.e. cardiopulmonary bypass, sustained life, that was developed in the 1970s. The schematic on the right, as you can see, there's a cannula that takes blood from the right atrium, then vena cava out the femoral vein to a pump outside the body, to an oxygenator outside the body, and then a cannula returns through the femoral artery to the distal aorta, providing perfusion to the body and maintaining organ perfusion, particularly perfusion to the brain, which oftentimes the rate-limiting step in these patients with cardiac arrest surviving is hyperperfusion to the brain. This is a patient that presented to our hospital in cardiac arrest. You can see the automated CPR device, the Lucas device providing the CPR. We placed a 25 French multi-stage venous cannula through the femoral vein. And then you can see I obtain arterial femoral access, and it's either a 15 French or a 17 French arterial cannula. Once these cannulas are in, you then hook it up to the ECMO circuit, and the patient then has full support. You can stop the automated CPR device. And again, this is important because it provides not only perfusion to all the organs, but particularly to the brain, because again, the rate-limiting step in these patients is anoxic brain injury. These are two patients that underwent eCPR in our institution. The one on the left, you can see, has diffuse cerebral edema and anoxic brain injury. This patient did not survive. The patient on the right, normal brain parenchyma. This patient survived and left the hospital walking. So again, very important to be able to have the automated CPR device, particularly when you're in the field coming to the hospital to provide adequate CPR, and then in the hospital to be able to maintain that adequate perfusion, particularly the brain, is where the ECMO comes in place. So just a little background. So when we look at out-of-hospital refractory pulseless VT or VFib cardiac arrest in the United States, there are over 350,000 that occur with a survival rate of about 10%. Now, a quarter of these cardiac arrests are thought to be due to pulseless VT VFib due to acute cardiac ischemia, i.e. ST elevation MI or non-STEMI. So, if you could potentially reverse the cause in these patients who have acute cardiac ischemia, then potentially you can reverse the cause of arrest and potentially these patients can recover. Now, these patients that present in cardiac arrest from the field, 20% of them will have spontaneous circulation, but the remaining 80% will remain in refractory cardiac arrest and essentially will pass away and die. So it's this patient population that we're very interested in, this refractory cardiac arrest population, where these innovative strategies that we just described, the mechanical CPR device to help bridge the patient from the field to the hospital, and then placing the patient on ECMO to maintain perfusion in more of a controlled environment, and then performing a coronary angiogram and looking for that acute lesion that resulted in the arrest, revascularization, and then potentially the patient may recover. Now, I want to mention that there are several studies, including our experience, that have shown eCPR to have encouraging outcomes in out-of-hospital cardiac arrest. However, to mention the non-shockable rhythms, PEA and asystole, have very poor outcomes. So most of these studies focus on ventricular tachycardia and ventricular fibrillation, as we did in our protocol. This is our experience that we published, and again, focus just on pulseless VT and VFib. In the next several slides, I'm going to break down our algorithm and go through that in a little bit more detail. So how do you develop an eCPR program? Well, the first thing you need to do is you need to partner with your local emergency medical service personnel. So we partnered with the Columbus Fire Department. You can see their ambulance picture there is on the right. Now, the city of Columbus is in the Midwest in the United States and serves about 2 million people. You have to have a partnership, a very close partnership with your emergency medical services, because it's the emergency medical personnel that will bring these patients to your cath lab, and the algorithm has to be very tight and has to be very well planned out. And I'm going to go through that in the next several slides. Now, if you look at the algorithm on the left, you say, this is simple, it's one page. I will tell you this took months and months of preparation, meeting internally, meeting with the Columbus City Department of Fire, having dry runs, practice runs from the field within the cath lab and so forth. And finally, when we hammered this out after several months, we went live. You have to meticulously look at your protocol, analyze the data, and make alterations accordingly. So let's break this down. So the first thing is you have to define what is refractory ventricular tachycardia fibrillation cardiac arrest. We define it as 3 unsuccessful defibrillations in the field. After the 3rd unsuccessful defibrillation, you have to have a mechanical CPR device. If you don't, then the protocol stops and the patient is pronounced dead. The reason for that is, again, as I mentioned, is you have to be able to provide adequate CPR when an ambulance is moving fast to get to your medical center. Now, a couple other things to mention is, roughly, I know it's difficult to tell in the field, but we included only patients from 18 to 75, and that any time upon arrival, if the patient was in asystole or PEA, it was a hard stop, and we did not proceed with our protocol. Again, this is because data shows that non-shockable rhythms have very poor outcomes with eCPR. Okay, so a patient meets criteria, 3 unsuccessful shocks, and eCPR alerts called to our medical center with one phone call. We have 1 number, and then the patient's directly transported to our cath lab, bypassing the R to save time. In the cath lab, our team assembles, and we assemble within 30 minutes, waiting for the patient. When the patient arrives, now we look at surrogate markers to help us determine now which patient will survive. If they don't meet these markers listed here, we do not proceed and the patient is pronounced deceased. If these values are met, then we proceed to ECMO. Now, what are these? Well, when the patient arrives, first thing we do is get an arterial blood gas. We look for a lactate of less than 15. If it's greater, we stop because data suggests very poor outcomes, and even if they survive, they're going to have very poor neurologic recovery. We look for a PO2 of greater than 50 to show adequate oxygenation. We look for an end-tidal 2 CO2 of greater than 10 that shows adequate CPR. Again, asystole at any time is a hard stop, poor outcomes. We stop the protocol. If the patient initial rhythm is ventricular tachycardia or fibrillation, but then converts to PEA arrest, that is a heart team discussion. And based on the available parameters here, it's a case-by-case decision. If these are met, then the patient's placed on ECMO. Again, 15 or 17 French arterial venous cannula and a 25 French multi-stage femoral venous cannula. Patients placed on ECMO, hypothermia is initiated through the ECMO circuit, and then the mechanical CPR device can be stopped because you're giving adequate perfusion through the ECMO circuit. At that time, because you're in the cath lab, we perform a coronary angiogram looking for that culprit lesion that may have resulted in ventricular tachycardia or fibrillation. If it's seen, the patient undergoes PCI and then is transferred to our intensive care unit, in which the patient will be taken care of by an intensivist. So let's go through a case at our institution. This is a 50-year-old male that was working on his car in his garage and had a witness cardiac arrest. CPR was initiated, emergency medical services arrived, and the patient was found to be in ventricular fibrillation and was defibrillated twice. Patient was in persistent VFib, thus a dual sequential defibrillation was performed. Columbus City Fire Department on the third defibrillation uses two sequential pads. The patient was persistent VFib, intubated, epi, amiodarone was administered. The automated CPR device was placed. Again, this is a must. If you don't have it, it's a hard stop. Again, because these patients do not survive due to inadequate cerebral perfusion. So you have to do everything you can to optimize perfusion of the brain. An eCPR alert was then called to our university, and I happened to be on call that evening. This is our coronary angiogram, but again, before the coronary angiogram is performed, we obtain that arterial blood gas, looking for the lactate, looking for the PO2, we look at end-tidal CO2. All the parameters are favorable, which again are surrogate markers to suggest survival and also suggest good neurological outcome. If they're met, then the patient's placed on ECMO. And once the patient's placed on ECMO, the automated CPR device can be stopped because you have adequate perfusion, particularly the brain, and that's when we perform our coronary angio. And you can see in this patient, he had an LAD stent with stent thrombosis. You can even see thrombus creeping back to the distal left main and to the ostium of the left circumflex. Here's the right coronary without significant disease. You can see here's the multi-stage venous cannula going from the right atrium down the IVC out the femoral vein to the ECMO circuit. So we proceed to PCR. So when a patient has a nasogastric tube and we have enteral access, we load with aspirin and then we prefer ticagrelor due to the quicker onset of action. If there's no enteral access, no nasogastric tube, we either give IV cangrelor, but to be honest with you, we really lean towards giving just a bolus of a glycoprotein 2B3 inhibitor, which then can buy you several hours to get an NG tube in and load with a P2Y12 inhibitor. And if you can't still get an NG tube in, then you can continue that infusion. We use unfractionated heparin for anticoagulation. You can see here our guide catheter, a coronary wire going down the left anterior descending artery. And then we perform manual aspiration thrombectomy just because of the heavy thrombus burden. As you know, our guidelines here in the United States, the American Heart Association, the American College of Cardiology, manual aspiration thrombectomy for routine use is a class 3. However, can be considered in select cases as a class 2B indication, and then we thought it was appropriate in this situation due to the heavy thrombus burden. We also performed manual aspiration thrombectomy to the left circumflex because if you recall, there was thrombus in the distal left main and the ostial left circumflex. Then we performed intravascular ultrasound, and we noticed that the stent that extended from the ostial LAD to the proximal LAD was underexpanded, which may have also resulted in stent thrombosis. So then we ballooned the stent to a more appropriate size to expand it. And this was our final image. So at this point, the patient was then transported to the intensive care unit, and we found a little bit more history on the patient. We discovered that the patient had a stent placed to the LAD about 8 months prior to presentation, and he possibly was non-compliant with his medications, which again may have contributed to the stent thrombosis. Patient also had a history of hepatitis C. The urine drug stream was positive for cocaine, and likely also he was abusing alcohol at the time. The patient underwent temperature target management for 24 hours. The troponin peaked just to 48, and the echocardiogram showed preserved left ventricular ejection fraction of 60-65. On hospital day 4, the ECMO cannulas were removed. On hospital day 10, encephalopathy improved. Likely contributing was alcohol withdrawal, and the patient was extubated. Hospital day 11, the patient passed the swallowing study and had an advanced diet. Day 12, physical therapy was initiated at bedside. At day 15, the patient was ambulating the halls without difficulty. And day 16, we discharged the patient to home. Not only did he survive, but he had good neurological recovery. So in conclusion, eCPR utilizes ECMO as an adjunct to CPR. A multidisciplinary team with close collaboration with emergency medical services is critical for a successful program. ECPR programs have shown encouraging outcomes in patients with out-of-hospital refractory ventricular tachycardia and/or ventricular fibrillation, cardiac arrest. And in 2017, our institution, in collaboration with the Columbus Division of Fire, launched a collaborative ECPR program for this patient population. I'd like to thank everyone for their time and listening to this lecture. Thank you.